Hey everybody, this is Dr. Owen Muir. I'm here to break down one of the more remarkable studies on treatment-resistant depression ever. So I was an investigator on this trial, and I also did a lot of advocacy to get this trial to happen, having published multiple post-marketing data sets prior to its publication. So this approach I'm about to describe had already been done in the real world hundreds of times before it was ever included in a clinical trial. So the FDA wanted us to have a comparison group, which was the original once-a-day transcranial magnetic stimulation, or TMS, done with the BrainsWay H1 coil. Done only once a day using an older pattern of stimulation, which takes about 22 minutes a session. Now, this technology has been approved since 2012, and it's been used in the real world a lot, so we already know it's an active treatment. In a non-inferiority design, what you're doing is comparing the already existing active treatment and the new thing, which you don't know is as good. And the question you're asking is simple, but I'll spell it out. Is the new thing not worse than the existing already approved treatment? And so that's what we were doing here. So what's this new treatment that has a 78% remission rate in the treatment of major depressive disorder that's treatment resistant for people who already haven't responded to medications or therapies? Well, it's the same physical device. It's the BrainsWay H1 coil, which has 12 magnetic coils on the left of the brain and 6 on the right of the brain, positioned at an angle, yada-da, already one of the better treatments for depression. Well, it's a shorter and faster version of the protocol. So the magnetic energy is delivered to the brain at 9 minutes at a go, and we're doing it 5 times in a row in a single day over the course of 6 days. So you're getting the depression treatment over with much more quickly. There were then some sessions after the acute course of treatment where people were coming in twice a week to get some more brain stimulation to allow for greater durability. So we're comparing an old thing that we already know works to a new thing, which is a faster version of the old thing. And what did they find? And by they, I mean me too, because I was an investigator on this trial. What we found was that the new treatment of doing it faster, 5 treatments a day over 6 days, each of only 10 minutes each, with 50 minutes in between. When we did that, it was non-inferior, statistically, not less good than the existing treatment. But both of these treatments, the once-a-day treatment we already knew worked, and this faster treatment, were both remarkably effective in treatment-resistant depression. So everyone in the trial had depression and not other diagnoses like bipolar disorder or schizophrenia. Those conditions were excluded. They weren't suicidal at baseline because this is a clinical trial and we routinely screen out suicidal individuals, and I have some debates about that with the field, but that's what you do in an FDA approval trial on average. And the patients were randomized to one group or the other. One group was getting 1 treatment a day, and the other group was getting 5 treatments a day over 6 days, not over 4 weeks. Now, you can't blind somebody to whether they got an active treatment that's only once or 5 times in a day. They're gonna know. And so what we ended up doing was blinding the raters in the trial. So the people who were evaluating whether the treatment worked and how well, who saw the patients at baseline and saw the patients subsequently, they had no idea what treatment they were assigned to because overwhelmingly they were not anywhere near the patients at the time. So they either did it by telemedicine or they were, in a different part of the building. We asked them at the end of the trial to make sure they couldn't tell, and lo and behold, the blind was preserved. So the raters didn't know who got what treatment, but the patients did. They were just asked to not convey that information. So it's not a traditional double-blind, placebo-controlled, randomized controlled trial because that might have been unethical. This is a really big study. 104 patients were in the study. And in that case, we're giving both groups active treatment. So we didn't have to stop the treatment at a midpoint because the active group was better than blah, 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 that's something you normally have to do. If something's very effective, you can't keep giving someone a placebo. So one of the benefits of doing a non-inferiority design, like in this study sponsored by Brainsway, is that you get data in much larger groups of people because you don't have to call your study off early. So there you have it. We have 2 treatments, once a day TMS with the H1 coil and 5 times a day over 6 days TMS with the H1 coil. They are not meaningfully different from each other, and 78% remission is what we saw in the accelerated TMS group, which was our experimental innovation. If this is the kind of treatment you want for yourself or a family member, meetradial.com is our website, and clinics like mine, which deployed this treatment in a clinical trial, can already deploy it in clinical practice. And we're working hard on getting it published, FDA cleared, and most importantly, covered by insurance subsequently. Thanks for joining me for this video.